a separate event with Ross and Liz, but the boot camps for building models.
And that, and replace it with a model. So thank you for taking the time. I know you're very busy. And thank you all. I already sent forwarded Nate's message with all links and other materials. Some of the new names and came up, so I'll collect those from you and then forward them.
And I'll see if I can post some more. Got some great questions.
Excellent.
And I'll see if I can add to the materials there and possibly to models there as well, so that you folks could, if those who are interested, could find out more.
Fantastic.
We have the question.
Oh, yes.
So
I'm being sensitive to you. I mean, we can save you.
So we were talking about this on the break. We were wondering, when you are setting up the model, are you using biostatistics or regression to do your initial assumptions?
That's right.
And then the model takes over.
That's a lot of the ways these models operate, and it's particularly common in some of our modeling. So we'll have, and you may have seen that actually in the model. There's some places where I've given, these are teaching models, and I've designed them to try to bring out certain features like where you'd plug in biostatistical parameters. So there's these indicators of where the betas are that could plug into certain relationships. And typically, so for example, we'll do a competing risks analysis involving progression to end-stage renal disease versus death for someone with diabetes. And the components that come out of that competing risks analysis in terms of the odds ratios, et cetera, for the hazard function, the baseline hazard function, we could plug those directly into one of these models to capture aspects of progression if we wanted to do so. In other cases, we may articulate it so that we don't have data available, and we'll have to pursue other strategies. But that's a big use of biostatistical modeling, is in estimating the parameter values that go into these models. Yeah, it's a great question. Other questions? Yeah. So maybe I'll just mention on these bootcamp front, it's very kind of Vish to mention it. I do run series of boot camps each year, and increasingly are doing custom boot camps for particular groups on specific issues, say social determinants of health, or on health services delivery, or factors having to do with life course perspective, maternal-child health, and these are week-long things. Where possible and where we can have the requisite TAs, we try to get out of them actual models that participants build for their area, so they actually merge with a model that's running, and they actually go through the hardest part of the modeling part, which is the first few days where you need someone nearby to say, how do I do that? You know, it all looks good on the screen, but how do I apply it to my area, so that they can grab me, they can grab a TA, and sort of get that help there with us. We call it an incubator. And basically, as I told Vish, in any case for these events, whether incubators or not, we typically try to get people building 10 to 12 models in the course of the boot camp. So it's not I build model. You folks are building the model with me, and you're adding to it. And often those models then serve as kind of the basis for thinking, how could I apply this in my area? So we run these things for health scientists. These are not for people with programming background and so on. They're for people who speak lingo of health science, and our TAs have that dual sort of capacity. They've built all these health models so that they can often communicate fairly well despite disciplinary boundary. You know, I would welcome any of your interests. There's a bit of information on the site about it, and I'd like to share any more information. But it's wonderful if we could do something here.
Yeah, I'm thinking maybe we should.
Fantastic. Yeah.
What is being applied to, for example, at the level of health system with the reform, how the system that is behaving in one way and introduce a change to all that?
Yeah. So thanks very much. Yeah, some years back, gosh, almost 10 years, I served on a panel that was advising the RAND Corporation on practices for modeling of health system reform to sort of understand the impacts of larger scale health system reform efforts. And and there's been some very interesting work that's been done in that situation. To be honest, some of the more well-known models I've a little bit of reservations about because I'm not sure they have the level of detail required to firmly sort of pick up certain effects, but it's a step forward in any case. And there have been some very interesting attempts to try to look at, how much, to what degree do you have to change capacity as well as availability of services, for example. So it's one thing to maybe open the availability so people who are from poorer background and involved now have health insurance so they could go see a doctor, but it's another thing if there's very few doctors in poorer areas, and so you've just shifted the you've shifted a bottleneck to actual access, and so how do you go about thinking about capacity issues at the same time as thinking about the wholesale sort of financing side of it?
Yeah, that's correct. Unfortunately, most of those assumptions are economic assumptions models and still using agent-based models. So we don't understand the behavior. That's why suddenly in Massachusetts, after the healthcare reform, people still are going to emergency care,
right.
Which they did not account for human behavior, right? So
that's right.
So they're mostly on economic assumptions rather than.
Yeah. And I think this you've your finger in it relates to one of the questions I got, which is, how do you capture the vagaries of human behavior on all this? And suffice it to say that it wasn't too long ago, within the past 10 years, that I remember being in a convocation of this group gathering of modelers doing infectious disease modeling. And, it's a very interdisciplinary group. We had people from public health agencies there, et cetera. It was great. We're having a dialogue. And I remember this issue coming up of behavior change due to changed risk perception. I think I may have been the one who brought it up. And one of the modelers said, we can't model that. And I said, well, why not? And he said, well, that's the area of behavioral science. And that's the area of psychology and so on. And yeah, well, if you want to really understand the effects of interventions, you have to start thinking about behavior change and social science considerations. And fortunately, the new generation of modelers now are rising to task. So you look at our work, you look at Liz Brook, you look at Ross Hammond. They're dealing with social scientists. We're looking at models of how people make decisions, which are incredibly successful. Scarily successful in the marketing area, for example. How do people make decisions as incentives changes, in light of their preferences, as the choice set changes, and trying to leverage those to give some insight into how incentive setting or provision or changing the pricing of goods or taxes might affect behavior of people with respect to tobacco, with respect to physical activity or what have you. And I think it's a very important area, and an area where, it'll be a long, hard slog, but where we can do it. It's going to require more meeting of the minds. And it's not going to be easy. Models are going to be able to make it a lot easier than the alternative, which is sitting back and trying to understand it on the top of your internet, which is very difficult.
Let you go next. So thank you.
All right. Great.
I would love to follow up if I can have your ideas.
Sure.
I'm really Peter scientist right now.
Oh, yeah.
But I didn't find his sport.
Oh, okay.
Like if there's a sport that he's there.
He used to.
Yeah.
He had the Center for Organizational Learning, but he basically went into a consulting, sort of management consulting reason, and I think it charges an arm and a leg. It's unbelievable. But John Sturman and Hajir Rahmandad, who's right now a visiting professor, will be coming full time. They're both extremely insightful on this front.
I'll reach out to you to see if there's entry level resources and
Sure. Here, I'll give you my business card, but there are some folks who have been active in trying to think about applying that to things.
I find it amazing.
Oh,
Very
sure. I should have mentioned I probably have 1,000 videos online about this stuff too. So if you want to look at it, I have whole courses. Basically, whenever I give a course at online, YouTube, and so they have cross-linked exercises and example models and lectures and slides.
Thanks so much.
Oh, great pleasure, Joe.
I've always been amazed and intrigued to understand how that applies. I'm a psychiatrist.
Right. Yeah.
And it's always tension between, for example, more neuroscience, science or psychologists, more philosophy oriented psychologists.
Right.
Modeling is sort of what you mentioned. I know we cannot model behavior.
Right. Right.
I remember a book has a very nice phrase. The only valid model for a cat is the cat. Preferably the cat.
That sort of idea, yeah. Yeah. That's really interesting and constraining, certainly.
Like you just left to thinking of a cat.
Exactly. Like we can't possibly yeah. So